Hello, everybody. I am Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, we have a superb panel and a great topic, optimizing ACL reconstruction. I'm going to pass over the moderating duties to Nirav Amin. Nirav?
Thanks, Ira. Thanks for having me. My panel is I have a distinguished guest and a panel of Oscar Vasquez out of Hackensack, New Jersey, and then Brian Gilmer, who practices in Reno and in Mammoth, California. So I think the key parts today to kind of take away from us is talking about the ACL fixation. And I think Brian will start us off with the changes. So I think historically we know there are challenges with the ACL fixation, whether on the femoral side and tibial side. Obviously, if you look at the dynamics and you look at the ISACOS study that came out 2 years ago, the changes in the graphs have changed as well. So if you look at a decade ago, autograft hamstring was almost 80% of the market in 2014. And the quadriceps has grown tremendously. So in 2023, the quadriceps is actually closing in on the hamstring market and it's actually flipping over. And the BTB market has actually came down a little bit in parallel as well. So there's a lot of nuances and changes in the graft positioning and the potential fixation. And this is where Brian can give us kind of a new intro on a new opportunity to potentially minimize the shortcoming of the current options available on the market. I'll give it over to you, Brian.
Thanks, Nirav. Yeah, I'm a heavy soft tissue quadriceps ACL reconstruction enthusiast, but I'm also a big believer that the ACL graft should be patient specific and not surgeon specific. So you shouldn't have a specific way that, how do you do your ACLs? It should really be tailored to the patient because of some of what we're going to talk about pros and cons. As we go along, we'll kind of talk about, unfortunately in my world in the ski population, I do a lot of ACL reconstructions and a lot of ACL revisions. And there's a lot of factors that we don't necessarily control, right? And so this is sometimes specific to your population. And so in me, it's heavy ski and snowboard related. And that's a different tear morphology, different associated injuries, higher rotational forces. So I might have different experiences than somebody who takes care of predominantly field athletes. Gender, obviously, age, not things that we have control over, bone density, and then the neuromuscular patterns. I just had a patient, a young adolescent female, that highest risk category. She went back to sport at 7 months, recommended against it, had a big effusion, had an event, luckily didn't have an ACL re-rupture, but scared herself enough to realize that these things still take time. And then as we get into things that we can kind of control, like slope, I'm doing a lot more slope reducing osteotomies. Nirav, Oscar, you guys doing any slope reducing osteotomies? Thinking about that more than you were maybe?
Definitely thinking about it more. It's still not something I do primarily. It's something that I consider. I've done it for, the person who comes in has had two, obviously has had multiple tears, revisions, and now you're starting to think, okay, we've got to change the patient. Still on my primary revisions, I look at it every time, whereas 10 years ago, I don't think I even looked at it, honestly. Now it's something I always make sure I get a full tibial film to see the posterior angle. So, but I don't do a ton.
Yeah, and Brian, a good question. I mean, I think the aspects are if you are going to go down the aspect of a slope correction, I think that's where it gets a little bit tricky, right? So I think historically, the challenge with the slope corrections is the accuracy. So I think with robotics coming into play and the nuances of like body CAD and all these other nuances that allow you to accurately place your jigs, open the correction to a instead of a macro correction, a micro correction. I think it helps us overall get to the slope correction that you're trying to achieve. I think the challenge is for me, I think Oscar probably in the same camp. I think we all kind of in Europe, it's well accepted on a slope correction. In the US, it hasn't come to the forefront as a correction in that level of setting, but I think we're all kind of there. We're at the forefront of it. It seems like, Brian, you've taken the leap of faith before us, but you're also seeing a patient population that's a little bit different than us as well, right? You're seeing people that are hitting contact injuries, high level of activity, field athletes don't see those level of forces on their correctable slopes. I think it's a little bit different than the patient population, probably Oscar and I are saying. Oscar, correct me if I'm wrong, but I don't see that patient population as aggressively as Brian sees.
Yeah, mine are mostly field athletes.
Yeah.
But I'd be interested to see, Brian, in terms of, yours are higher forces. So you would think it's more the external force that leads to the rupture versus something endemic of the patient. So I would think you would be less likely to correct it. I mean, obviously, if you're on multiple revisions, that's a whole other ballgame. But do you consider
Yeah.
it on primaries when, obviously a non-contact runner, you start to say, hey, what does this patient have? Why are they tearing their ACL just doing something simple, blowing out your
Yeah,
knee?
so super quick on that. One, we should all be getting laterals that go 15 centimeters down the tibia. If you're serious about looking at this, that's what you need to do. And I think we more need to be thinking about there is this higher risk population group. So while I'm not slope correcting every primary ACL, I am modifying techniques in my primary ACLs to try and mitigate the risks associated with these because it's not practical to do slope reducing osteotomies. When I do, I can typically do them in a single stage revision, as Nirav said, because of improving technology. But optimizing some of these other factors with the primary is getting more important to me as we're seeing more of these patients who have these risk factors. A lot of the focus on factors we do control is, the conversations get a little worn out on graft choice and femoral tunnel position. Now, those are the two biggest risk factors for revision, but I think we need to again expand our thoughts beyond those things that kind of get hashed over and over and over again in meetings. So, for the purpose of our conversation here, let's agree that the graph, position needs to be right. You need to do a good job, and I think there's better tools for learning that now maybe than there were being. We're doing better in our fellowship programs. But just for Nirav, I know you do some quadriceps ACL all cell tissue quad. What's kind of your size and length going, and has that changed as you've gotten more experience with that graft type?
Yeah, Brian, good question. I mean, I think I used to cheat a little bit. I will warn you. I went from all soft tissue, and then I got concerned about the fixation on the femoral side and tibial side going all soft tissue. And I went to a bone block harvest on the superior pole of the patella. When I went to a bone block harvest, the bone block on the superior pole of the patella is very different than the inferior pole of the patella. So on the inferior pole of the patella, you can actually harvest almost like a trapezoid. On the superior pole of the patella, you cannot harvest a trapezoid. It almost comes down as a slope. So it's very tricky if you're doing it early on. So I could tell you I have gone back to all soft tissue. I'm a little bit cost conscious, right? So for those who work in an ASC, I don't use a harvester. I literally make an incision on the top. I use two Army Navies or Sens, and then I actually use the DePuy catamaran blade that's 10 millimeters. I will try not going full thickness, but if I go full thickness, I'll take it. But I try going just above the full thickness level. And I don't actually worry about the full thickness of the quad. I actually don't like the water extravasating through it. So that's why I try to not go full thickness. And I try to take 70. And my theory is I could try to go 25 in the femur, 25 in the actual inarticular joint, and gives me 20 to 25 coming down in the tibia. And that's my logistical thought process.
Yeah, I think that's great. I have reverted to I was taking tens, I was taking full thickness tens
Yeah.
that were 70 and they were rectangles. And I think we're learning that's too big for the notch of a lot of people. So I'm down to 9, maybe even 8.5 in a smaller female, and really trying not to get into their VMO where they're going to have donor site morbidity from that. And as well, staying partial thickness and just loosely reapproximating so we're not over tensioning that. So I think those are modifications of the quad graft that I've picked up. We started doing this in 2015. And I think you can get donor site morbidity there. It is not, we're going to learn that it doesn't solve magically all of those problems. And so a little bit about that there, the newer data that's suggesting more difficult or higher risks with With hamstrings, and I don't want to steal Oscar's thunder here, I wonder if that's a size thing. I wonder if it's a soft tissue fixation or independent. But certainly there's long-term data from Pinchewski that those patients did incredibly well over a long period of time. So I think it's a viable graft option still. And then that kind of brings us to the discussion of aperture fixation versus cortical fixation. And this is something I think doesn't maybe gain enough attention. So, a little history lesson. What graft were you doing when you started practice, Nirav? We won't say exactly what year that was, but and maybe you too, Oscar. And are you doing it differently now than you were maybe a number of years ago, if you will?
Yeah, I mean, Brian, I could tell you in my fellowship at the Cleveland Clinic, we did BTB and hamstring. And I would say in my training, it was almost 70% BTB, sorry, 70% hamstring and 30% BTB, depending on the attending, obviously. And when I came into practice, I had a switch where I switched to BTB. And then as the comfort level of the quadriceps grew, my comfort level grew, and I slowly started switching over to now I'm probably 50-50. My BTB is still to contact athletes, but I am aware of the donor site challenges with the BTB, and I'll go to a quad in a female. Or I like your tip and tricks, which is very important. The size of the quad is very important. Do not try to harvest a 10 in a small girl. It's a very robust pass. And especially when you actually pull the graft through the femur, if you don't kind of like mushroom if you let the head kind of stay where it is from the harvest site and you don't actually trim up the edges, just like a BTB graft, it will actually get stuck on the femoral tunnel. And if you pull really hard on it, the graft will actually bunch up on itself and it actually won't go into the femoral tunnel. So I will tell you one of my tricks, Brian, that I use is I soak my quadriceps tendon in a vancomycin soaked sponge, which just came out in an article in AJSM talking about the infection rates lowering. And the last thing I do to really help myself, I soak the graft in mineral oil before I go up. And it's very helpful. So if anyone's never done that, it's actually super helpful to just actually dip it in mineral oil right before you pass the graft up. But I think it's really important. You made a very important point when you are harvesting the quad, and I just want to mention this, right? Because we're going to talk about fixation a little bit in a couple minutes of quadriceps. It's very important not to veer towards the VMO. That's when people get quad atrophy, and that's an elongation kind of period of rehab. So we'll try to stay on the central aspect, just like you would on a patellar tendon harvest. Do not veer yourself towards the VMO because you're going to get quad atrophy and you're going to get delayed activation of the quadriceps tendon. Very important.
And be aware that we make straight incisions, but in a large proportion of people, that the quadriceps tendon drifts laterally. So imagine somebody with a larger Q angle, somebody with valgus, those smaller females that work. Sometimes people tell me, I keep getting these short grafts. And it's like, no, the tendon's going laterally and you're going straight in a straight line up their femur. And there's just a lot of people who that's not the case for. Real quick nod to the thing about the vancomycin dredging. Also has some good literature now to support that doing that does not compromise the biomechanical qualities of your graft. And that's been proven as well. Helpful. Oscar, are you fixing these grafts the same way you've been for your whole career? Or has that changed?
No, it's changed. I mean, I did my residency 03 to 08. 08, 09 was my sports fellowship. So, I went through all the different fixations, transfix, interfix. I would say it was about 50-50, my residency, hamstring, BTB. There was no quad to speak of. I was, during my fellowship, we were doing a lot of allograft and, all inside technique. And we'll talk a little bit about, retro screws and messing around with that. My practice has gone, I don't do much BTB anymore. I do talk to the patients about all the major grafts, and I actually leave it up to them. My thing is I think they all work, and I think they're all viable grafts, and have discussion with them. The same reason you guys may have decreased your BTB is anterior knee pain. But if somebody comes in and they had a BTB on the other side and they did very well, or alignment things, the same reasons we choose them. I'll still do BTB. I do for quad. I do undersize. I do 9 millimeters. I do partial thickness. Same thing you guys do. The thing that has changed as I go, I started with that very small incision. Now I want to see a little bit more. I want to make sure, and I stick the scope up there, put a spinal needle, make sure that I'm aiming dead center, and make sure you can see that, because it's very easy to deviate from bigger quads. It's quite easy to do that, and I think there's a learning curve to. We've all done it where you skive and you get one of the advantages of quad is, hey, you can, hamstring, sometimes you get a small graft. Quad, you always get you don't always get
yeah, if it's small, it's your fault. If it's small,
right,
it's your fault. Yeah,
right, and you can correct it, but that's the learning curve of it, and thankfully that's gotten better. But
well, let's
that's
talk a
sort of
little bit about this. You touched on kind of the pros and cons of each. This is an open evidence graph, and I in typical orthopedic fashion, I tagged it with red for the bad. And you kind of see this is just comparing classic interference screw, which historically we were doing first and more commonly with BTBs. And then adjustable loop cortical buttons came out. I was training with Roger Larson at the University of Washington. So early endo button, fixed, doing math, 7 millimeters added for the button to flip and this kind of thing. And so any comments on this? I've often thought it's a little bit interesting that the tibial tunnel widening, and I've seen this anecdotally too, doesn't always follow what you would think, and that that the tibial tunnel widening tends to be more, particularly, I think this is biocomposite screws that probably drives that. Whereas femoral tunnel widening, we talk a little bit more about the bungee cord effect and the windshield wipering effect. But any thoughts on this? Are you guys fixating on, I'm using an adjustable button on the femur and an adjustable button on the tibia with my quads, and I came from that the all inside, quadrupled semi T, and just never quite felt satisfied with that. And so any thoughts on this? Or are you guys using buttons on both sides or using a hybrid fixation? What are you guys doing?
Yeah, Brian, I think good questions, right? And a loaded question, and I'll kind of be very quick in synopsis on this. I think the reality is when you're using an all-inside construct and you're using adjustable loops in that level, I think there's no clinical study on PubMed. I published a couple on adjustable loops and looking at displacements on biomechanical markers. The challenge with all the adjustable loops with an instron model is it depends on the angle of the instron. It depends on the slope or the direction of the tunnel drilling. It depends on the friction of the graft related to the tunnel, how there's a lot of variabilities, right? So the factual basis, adjustable loops have some level of displacement. I think we can all agree to that. No one's going to disagree with that. And I think we can all agree that ACL displacement of more than 3 millimeters leaves you concerned for failure. So if you look at the best biomechanical data on the market, they all have 1 to 2 millimeters of displacement. So if you do two all inside buttons, then you're getting close to that 3 millimeter level. And I think that's why the internal brace came out. That's why the bio brace came out. That's why these augments came out to avoid that cyclical displacement and offload the graft and the adjustable loops displacing. I think that's where the answers are kind of, we're looking for the answers. How do you have an implant? Or how do you have something that reduces the level of displacement so we can get under that magical 3 millimeter mark? Is it kind of what I think about in my head?
Yeah, and in talking about this early on, this is a paper that I wrote in 2015 with my partner Tim Kroll, and we were trying to use a soft tissue quad, but still have aperture fixation in the sense that the loop of the button would be buried in the graft. So the distance between those two adjustable loops, when you whip stitch them, you'd have your 20 or 25, like you mentioned in the tunnel, 20 and 25 in the other tunnel. The remaining graft is across. But we were already at that time thinking, well, what if the fixation points were right at the aperture, but we still got the benefit of the adjustable loop buttons? Will that help us? And this is the technique that we've used for years. It is a little more difficult because the end of the graft can knuckle over. So you have to have separate graft sutures that guide it into the tunnel and then do your final tensioning with the whites. This has kind of been abandoned now, but I sometimes wonder, we know that working length, just like working length with fractures, is more, the aperture fixation that we got with the screw meant the working length was shorter, but you still get the retention ability and you still get the cortical fixation of buttons. So you're making it not dependent on bone density. And you still got to use your buttons on both sides. So we were thinking about, can we combine the benefits and eliminate the drawbacks? But I completely agree with you. I think fundamentally, I was still seeing that when you bend this knee, it's not behaving completely isometrically. And that there is a capacity for loosening there. And this has been published in a couple of places. It's sort of just an unfortunate truth, and this is what Nirav just said. There are data, and it depends how you've done the studies. But generally, we can agree that most of these constructs, even if you tie knots over them, which I've done, it helps, but it doesn't solve that problem. Maybe a less discussed thing that I'd be curious if anybody else, does anyone else use fixation of buttons on both sides? Oscar, Nirav?
I do
I
hybrid.
do.
Okay.
I do, and
So,
Brian, and this is interesting, right? So the tibial button tilting, it's very interesting because if you actually look at, so we are in the process of doing a little bit of publishing in this in itself, and this will make sense, I think, once you kind of just think about it. So step back and think about this. If you have a button on the tib femur and you have a button on the tibia, it's under tension. And then it goes under cyclical displacement. What essentially happens is the suture in the tibial tunnel is at the superior portion of the actual opening of the tibial tunnel. So as you cyclically move the knee from extension to flexion, whether you fix the meniscus or not, irrelevant. Essentially, what happens is it cheese wires and it creates a superior migration of that button. And when it creates a superior migration, you can see on this X-ray, it creates an inferior tilt where the button caves in. And the reason is because there's so much tension in the superior portion of the actual bone. So when you're using an all-inside construct, the shortcomings of it are there's nothing holding the suture from migrating superiorly, right? And that's the challenge of it.
and so different things have been done to address this, but one thing I've observed is, I fixed this in extension with my thumb over the hole, and that button is sitting flat. I routinely get x-rays at 6 weeks, and they all look like this with the knee in full extension. So that tells you that button is moving, right? And the other concept that we often forget about is that the direction of pull is more linear. And so the graft is being pulled in that direction. So of course, the button is going to end up perpendicular to that direction of pull, right? And the thing is that adding backup fixation on the front of the tibia with like a 4.75 millibio composite or peak anchor, it doesn't effectively bring that down or change that orientation. Ask me how I know. So this idea, I've seen this with suture cutting through soft cortical bone, and I've seen this in meniscal roots as well. As you tension the meniscal root and in soft bone, you can watch it cutting across that bone. So it's interesting. People are also thinking the same thing about, how do we optimize this a little bit better? And essentially, this is Clayton Newell and his group with very recent from this year's study, just talking about all of these issues and their point in tibial fixation. And so I think some of what we're seeing is also the use of these additional augments, whether it's somebody mentioned BioBrace, which I have used to augment hamstrings, suture tape augmentation, like an internal brace with a suture, which we've used, and then increasing LEATs. Really quickly, do you guys think the LEAT is truly an ad, or do you think it's accommodating something that we're not getting right with our primary ACLs? Do you think all of the people that we're doing this in now have anterior lateral capsular injury? Or is it, are we ravenously adopting something that we're being a little bit overzealous because of I'll get good study.
I think it's the latter.
Yeah, I mean, Brian, I can't speak from a scientific perspective, but I can deduce this. I can say doing an all-inside soft tissue graft means there's adjustable loops with displacement of 1 to 2 millimeters, which is past clinical failure load. So I think an augmentation of suture, BioBrace, whatever you're doing, unloads that aspect, which is right here. And then I think the secondary endpoint to unload that even more is if you do an LAT or an ALL, you're unloading that to a secondary level. So you're unloading the buttons from stress points where you're not having the level of displacement. And so again, I couldn't tell you from a factual point, but we've never had fixation that doesn't have displacement, right? So like you can't fix something that doesn't have displacement if you're using adjustable loops on both ends.
Yeah, and just real quick for fun, what percentage of your patients, all comers, let's just say for fun, are getting a lateral extraarticular procedure of some kind in 2026?
10 to 15%.
About the same. All revisions, and then the high all teenagers, young females.
I mean, I know, Brian, there's some people doing ACL repairs instead of a reconstruction, and then they combine that with an LET or some extra-articular ligament reconstruction, and that's their kind of thought process. So again, everyone has all kinds of different nuances, and I think part of it is because we're accommodating some level of displacement with our implant choice in the graft choice as well.
Yeah, totally. So, thinking of combining these things into one structure, as I said before, I haven't really been satisfied with a separate anchor fixating that. I feel like it still just cuts through the soft metaphyseal bone. And so I had gone through a phase where I was just like, well, gosh, I'm just going to put a screw in, I'm going to tie, and then I'm going to back tension to the femur. But then, that kind of led me in a roundabout way to this implant. Which has a couple, this is the quad lock, and it has a couple of advantages that I like. So we've been doing this for a while now because of that biplanar fixation creating friction in the tunnel. I still get to keep the usability, the friendliness. Let's face it, adjustable loops are nice to use. They are very surgeon friendly. That's why I love using two of them. And I get to use independent fixation of a backup suture without using another anchor and without that being independent and without that being dependent on the metaphyseal bone because it's going through a PEEK implant. So it's not going to cheese wire through a PEEK implant. And then, so for me, I've really liked being able to cycle the knee, get the graft the way I want the graft, and then tension the internal brace sutures the way I like, and then set the screw to set the tension of both. And so real quick, we'll kind of show how that is. I promise it's very short. This is about 30 seconds, but the other thing I kind of like about this is it follows a kind of standard workflow. So here, we have a small incision. You can see there's my quad harvest incision. There's an LEAT over there. I'm impounding this in on the inserter. That's going in parallel exactly to the direction of the tunnel. And I'm using the adjustable loop over the screw. And then the screwdriver goes on and it sets and fixes that. So I get the benefit. And if I want to retension, I can loosen that screw, cycle the knee, and then reset the set screw. And that's smooth. It's not going to chew up and damage my adjustable loop device. I also kind of like this because I work at multiple different facilities, and I'd be curious about you guys. Do you use the same implants at every facility? Because I actually end up using slightly different stuff depending on where I am, cost considerations, politics of facilities, hospitals, and ASCs. And this you can add, and it's agnostic of whatever the adjustable loop device is. What do you guys? Are you kind of all one vendor? Are you kind of mixing and matching? What's your experience?
I'm mixing and matching because of approvals in different centers, different purchasing groups. So it's some places you're allowed to have certain things, some places you don't. That's just I've limited by politics. Yeah, for sure.
Yeah, I mean, I think, Brian, the advantage here is, right, you just need an adjustable loop that doesn't have a button on it. and you could bring it underneath the screw bed like you did there. I think the important thing there, technique-wise, that you just showed right too, is where you pull on each suture slowly, it reduces it down. And I think this is what you were alluding to earlier, right? So historically, if I'm using a internal brace, if I'm using bio brace, or if I wanting some level of contraption for some level of fixation internally to unload the graft internally, once the adjustable loop is down to the tension you believe appropriate, you can actually pull your internal brace to whatever tension you wanted, and then you can put the screw down because remember, the cradle of the adjustable loop is below the screw. So at that point, from a financial standpoint, you no longer need that secondary implant, right, to come down on the distal tibia, on the proximal tibia to fix in with an anchor fixation. And the other advantage is, right now, we'll talk about it a little bit later, but the displacement, because the implant is going in a biplanar fixation, I think the word biplanar becomes absolutely paramount. You're not losing that cyclical displacement. I think I will address really quickly, Brian. I'm gonna actually pass this to you, right? And this may help a little bit. One was talking about like I know I briefly touched on the bear, and we'll quickly go over, but there was a question type about, remember, the bear has been shown to be non-inferior to hamstring ACL, not the gold standard. We won't allude into it a little bit, but I will kind of bring it down. Have you done a bear with an internal brace coming down or protecting it? I know you like Vicryl suture, if I remember correctly, as your kind of internal
Good
brace.
memory, yeah.
And Oscar, if that's the case, and Brian's used Vicryl, have you done a bear, Oscar? If you jumped on the bandwagon, I have openly, and I do an internal brace with the bear, and I put it into a Bonza mini implant, and it's the same technology, same process where I like it, where I put the implant in, I drill a tunnel, I shuttle the suture down, and I lock it into the same level, very similar to what Brian just showed here. So I do that on if I am going to do a bear. But Oscar and Brian, thoughts there kind of moving forward?
I use yes, I use internal brace with my ACL repairs
Yeah.
with Bear as well.
Yeah, and probably worth noting, I work with fellows, and sometimes when we final tension the graft, we'll put it in full extension. But if you're not careful, somebody will go to retension the tibia, they'll lift the knee off the bed, right? And the knee will go into flexion, and then they'll tighten, and that's irreversible. And so with this, I like the fact that when I walk out and I've set that screw and they're closing, there's no chance that somebody's going to bring the knee into flexion and as they're tying one of those sutures, all of a sudden take out some slack because grafts are not perfectly isometric, and that means they're tending to loosen in flexion. And if somebody pulls one of those strands and tightens it more in flexion, that patient's going to struggle to get extension. It's like that little lapse of attention at the end of the case, and I've seen it happen. I don't know if you guys have had that struggle before. I'll throw my fellows under the bus, but it's me too. It could be anybody. It's not hard to make that mistake.
Yeah, and Brian, I'll allude to, right, where this is where a little bit of value add comes in, right? When you're a fellow going into practice, and I have fellows who work with me, I'm fortunate enough to be part of the Kaiser Fellowship for Sports, and I have some fellows who work with me as well. When you're going to new facilities, unfortunately, or you join a group, you don't have the ability to choose the implants. The implants choose you, right? Your senior partners have set the bar, set kind of the implants at your ASC, and you can obviously choose what's on contract. But think about it this way. We have three surgeons on this call, yourself, me, and Oscar, and we're all using different implants based on site of service, which tells you some of the choice that we historically had at centers for surgical choices of implants are no longer existing. So this allows you a cost value perspective. I think I will allude to here very importantly on this design. So Brian, do you remember you showed us the X-ray of the implant tilting, right, in flexion, and then moving over time, and you drew the perpendicular line on the slide before. This is the value of having something. So what I call where the sutures are going under a roof of an implant. So therefore, you can't have that superior cutout and shortening of the implant where you have the bungee cord effect taking place. So that's the real value add of having some level of, I call it protection or shield coming up, where it doesn't have the ability to shorten and migrate superiorly. I think that's a real unanswered issue. We're working on some data controls, and we're looking at some bone blocks, looking at the superior migration through cyclical loading, but it is an absolute fact that happens on adjustable loops when they're not in something that's controlled environment.
Yeah, small technical pearl here. These come in 9, 10s, and 11s. And if I have a 9 or a 9.5, I'm going line to line. But if I have a 9.5, I'm going up to a 10. So I'll go half a size above. So I'll either go line to line or half a size above. Here's just some internal data showing that really remarkable low amount of cyclic displacement compared to an adjustable loop button. I actually went and dug through these citations last night, and I was verifying all of these, and so they vary from one to one, but if you cycle them long enough, you're going to get 2 or 3 millimeters on most of these devices. So
And Brian, can I say one thing, right? Even on the adjustable loops, right? Every company has a different level and thickness of adjustable loop at the cradle or the
yeah,
saddle of the adjustable loop, right?
yeah.
But one thing you'll notice is if you use one company, it'll actually come through as Brian was doing the quad lock, it came through pretty easily. If you use another company, their suture is a number 5. So it's actually really hard to shuttle that through because it's such a thick suture that actually when you're shuttling it down, it actually is really hard to go down. But what you realize is when you use that implant and you put a probe back in the knee, and I'm sure Brian and Oscar, you've done this, it's probably the most robust graft you've ever seen under tension that at least me clinically I've ever seen. Like the graft does not move, like once it's under that tension.
Yeah, it's very gratifying too because as you're tensioning it, and I like tensioning with the adjustable loop, it's that direction of pull concept. It's really snugging that into the bone, and so it's just very gratifying. Feels very robust. You
And
mentioned a
Brian,
little bit about X-rays, so I just kind of wanted to show
yeah.
those. But here they are, and these sit flush, and the X-rays looked at. You can see the peak just very lightly around it, and so I've expanded this. This comes in a peel pack kit, not just to ACLs like primary ACL reconstruction, but as you mentioned, ACL repair with augmentation. But also revision cases. So here it is with a mini. That's combined with an MCL, which you see the low anchors, and then a root anchor, and then the Abanza device, and then also PCL. I do double bundle PCLs. That's sort of a whole nother ball of wax. If you really want to flog yourself, do double bundle PCLs. But I do feel like they have less creep. So.
Yeah, and Brian, it's really interesting, right? Like Oscar, what are your thoughts on this, right? I think if you look at the PCL historical data with the killer turn, and I think most of us will say let's say post-operatively, you have a firm endpoint, but most of us will say you end up with a grade 1 or grade 2 with an endpoint with a posterior sag of a touch. I would say to you, part of it is related, and I will tell you, I don't do a double bundle. I think
Yeah.
they're very technically challenging, and my patient population in a trauma center is obese and not willing to actually go back to any level of activity. They just need a stable leg so their knee's not subluxating out the back. So for mine, I'm using an allograft, but I think I like the satisfaction of having one level of the side of the implant, not having the ability to creep over time.
Yeah, because every time that patient is supine, gravity is pulling on
Oh,
that
yeah.
PCL graft. And so everything that I can do to decrease displacement and still be able to use my adjustable buttons is a benefit. If you're wondering why those buttons are a little bit large or patients with lower bone density in that distal location, it's very different than where an ACL tunnel goes. A small button can actually intussuscept through the cortex in that location, and you can lose fixation on the femur. Ask me how I know about that. Uh, so.
So Brian, there's a quick question about are we doing instrumented studying post-op for stability? That is a great question. We are doing prospective data analysis, right? So we are looking at KT 1000. So I know it's a little bit historical, but we are looking at testing models moving forward. We actually are thinking about working even through gait analysis of return to function, one implant versus another. So I think that's a really good question. But I would tell you very openly, we wouldn't be able to answer it scientifically because it hasn't been proven to date. So, but that's a great question. We're looking at that data set. We just haven't worked on it to that level. Oscar, you want to
Yeah.
jump?
We'll
You
just
want,
throw in my,
yeah,
let's
perfect.
see, share my.
And Brian, can I ask while we'll bounce through right a little bit. So like
Can
I
you
would
guys see my screen?
Not yet, Oscar.
Really?
Like Brian, the one thing that I also like, right, is when I'm tensioning the implant and I like where it is overall, what I like is as the adjustable loop is compressing against the implant and the screw, it's actually pulling the implant against the tibial bone, and then it gives you a compression fit, and then the screw goes down. Let me ask you a different way, Brian. Does that leave you, for me, that leaves me a little more comfortable, right? Because now the adjustable loop's on a cortical button and it doesn't have the ability to move because it's locked on a cortical wall. I think that leaves me a little bit of comfort from the historical norms of where I'm at. And that's why I've actually moved over a little more over to quad from the BTP era. I know you're doing skiers and so forth. What are your thoughts there?
So totally fascinating. The nature of my revision procedures have changed. Before I was doing all quad, nobody else was doing quad, so it was all available for revision. Those were happy years for me. Unfortunately, those years have come to an end, and so now I'm doing more BTB fixation because the quad isn't available because the failures I'm treating are failures of quad. So. I think the for that um, I have shifted to kind of what becomes available. Although I have done some contralateral quads, but I found that that's been pretty rough on patients. They have not liked that, and I have not had a lot of problems if they didn't have any donor site morbidity or anterior knee pain. Going back to a quad after a BTB or a BTB after a quad, I haven't had anything at least catastrophic like extensor mechanism failures or anything like that. So I don't know. Maybe stay tuned.
Yeah, always gonna have one coming up, right? Anything you operate on, you're gonna have one coming. But Oscar,
That's
we'll turn over to you with the hamstring.
Can you see the screen?
You can. You're up, Oscar.
Oh,
Thanks.
perfect. All right. So, Oscar Vasquez, I'm chief of Mountainside, HUMC Mountainside. Also work with Rutgers and the Hackensack Medical School. So I'm going to be talking about the implant for hamstring autograft. We went over grafts and very similar looking to the quad lock, just a couple differences in terms of how open the aperture is and designed specifically for graft passing through and not just suture. But again, we talked about the problem. We're trying to minimize ACL failures. There's a lot of different ways they fail, and one of them we're trying to address here is tibial fixation specifically. So it can obviously fail from the angle of the tunnels. We've talked about the different types of grafts, poor technique, but we're looking at tibial fixation here. So what was the standard of care? Interesting thing, when I was a resident, I first heard how we fix the tibia. I thought to myself, I was like, wow, we just kind of shove a screw alongside and it's a friction fit and that holds. I would think it would just, with the forces of the knee and running, it would just slide. Obviously, it's done fairly well and it worked. And it was one of the things I was shocked about. But it is impressive that just compression and friction holds. Obviously, this relies on the bone interface. Poor bone is a problem. Another problem with interference screws that obviously can be problems is as you're putting in the screws, it can macerate the graft, damage the graft as you're going in. Does this have an effect? Also, it's a pretty long implant. And also when you look at revisions, a lot of times you see graft widening and a problem with these screws. So looking for improvement like we always are in medicine. We're looking for an improvement here in the tibial. Again, the problems just like Brian talked about, failure rates. If you have a patient with really low mineral density, but that interference screw, you don't get that happy squeak we all look for, right? When I once had a tech, I said, I'm not getting the squeak. And then he squeaked for me. He just went, squeak, squeak. Are you happy now? Yeah. So, which I was not, obviously. We had to back it up and do all that. But that's one of the problems we're looking to help. And, for a long time, we were using interference screws. What can we do better? This is older technology. Can we do something that's biomechanically stronger? So when you're looking at the washer cap and here's the implant at the top, and this is a peak implant, there's an opening. I wish we could see the opening. It's just the graft passes through the implant, and then the screw goes in and lock it, and like a washer cap, it's holds the graft. So it's really two independent fixations. One is the implant to bone, so that you see that sort of, for lack of a better term, that wing, or that top wedge is really kind of holding against the cortex, so that holds the whole construct against bone, and you're dependent on cortical fixation. So you're not worried as much when you have this softer cancellous bone, and then obviously the tissue to the device. So the screw, the washer cap holding it against the peak holds the implant in place. And we'll show that from the biomechanical studies, there's higher pullout strength and there's much less displacement. And again, not dependent on quality of bone. This is ideal for revision, where if you have tunnel widening, it's not in the cancellous bone, really not an issue. So this is good for both older and younger patients. And these are looking at some of the biomechanical numbers. It's the strongest fixation in the market. It actually had the biggest difference in lower mineral density. If you look, it's 860 newtons. This is the blue line compared to competitors. Significant difference in strength. And then when you look at displacement, the washer cap was 0.5 to 0.6 displacement, where you get a lot more displacement with the other interference screws. And there's really no displacement against cyclic loading. And again, the bigger difference is that lower mineral density. And why does this all matter? I mean, maybe this displacement, as we talked about, displacement leads to higher re-tear rates, also down the road effects. Could this be the reason that we're still having difficulty stopping osteoarthritis down the road? And we talked about this a little bit. There's, with cortical bone fixation, you have to use a backup for the internal brace if you use it, or if you're worried about fixation, use backup screws. If you're cost conscious, you have one implant that addresses both. And then one of the biggest advantages of the washer cap is if you're not happy with the tension, you can just loosen the screw, re-tension it, pull it down, pull the graft down a little bit harder, or if you want to pull down or even loosen, if you're not happy with the internal brace, it's too tight, you loosen it, and it doesn't affect the graft. This is a smooth screw. The washer cap is smooth. This is different from an interference screw. If you're not happy with the tension of an interference screw, you have to back it up. Then you're sort of grading the graft again. You may have to get another screw, which increases costs. So it's certainly another advantage. And it comes in multiple sizes from 8 to 11. So in terms of a case presentation, pretty straightforward, other than this being a chronic ACL. So I get a lot of these people who, for whatever reason, don't fix their ACLs and then want to get back to sport. So this is a 41-year-old healthy guy. He was 8 years status post his ACL playing soccer. Didn't fix it due to responsibilities in life. You want to get back to sport, no past medical history, standard MRI, standard mid-substance tear, preoperative x-rays, a little bit of medial narrowing, 8 years without an ACL. We'll do that. Simple interop picture. This is a chronic tear. You can see the stump. There was a little piece of graft that was still remained attached to the PCL, which probably gave him some stability. And here's the video for the washer cap. So essentially, it doesn't, like Brian said, it doesn't change much of what you do. Basically, you still put the pin for the tunnel. You drill the tunnel. You over drill a little bit the cortex for the little different techniques for that. And then, but once you have the pin in place and you've drilled the cortex, now we'll get to. This is what you add. So you've drilled the tibial tunnel, and you put this guide for a guide wire. And the reason you have this guide wire is you have to sort of ream so that the implant will sit flush because it has a little bit of a belly. So you put the guide, you put the pin in the proper place, you pull it out, and then you ream, which is perpendicular to the tibia. So again, so that the washer cap sits flush. And actually, the next generation of this implant is actually taking all this out. So all you have to do is put in the pin, over drill your cortex a little bit, then drill your tunnel, and then put in the implant. And this is putting in the implant. Just follow the direction of the tunnel, which is actually key. You can easily go in a little too perpendicular, so you have to make sure you're following. So you push it in, and then you take off the screw that holds the guide to it, and there it is. And now the rest of it is your standard ACL. You pass the graft through, flip the button on the femur, verify that it's flipped whatever way you do, and now you have the hamstring graft coming out through, and you hold the tension, and hold it in whatever position you do, and then just tighten down the screw. And there you have it. And you're done. So it's not much. Yep.
And I was going to say, right, so there's two things that we could probably highlight here, right? So the quad lock doesn't need the steps that you're describing here on the washer cap. The Gen 2 of the washer cap, as you alluded to, will alleviate all these steps, will be a single level implant going in. So I think to be fair in the market, and this is a really good picture of a ACL graft with the BioBrace, but to be fair, the Gen 1 has a few steps to it to get to the biomechanical data of optimization, but we're trying to make the usability catch up with the biomechanical data. And that's why the Gen 2 of the washer cap that will be coming out, and the quad lock as well, if you notice, doesn't have those steps because they've been eliminated to make the nuances and workflows very similar to what you're currently at.
Exactly.
So, Nirav?
Yeah.
It's Kevin. Hi.
Hey, Kevin, how are you?
Good. So I wanted to thank, first of all, Brian, Oscar, and you for bringing a lot of concepts together, and Joey for letting us talk about it. I guess in summary then, if you're going to be a soft tissue quad or hamstring gentleman, you've really driven home the point that there are devices that reduce displacement, and one should reconsider what you're doing in your old ways to adapt perhaps, and you can tension both. If you augment with whatever device, you can tension that separately also from your graft, which gives that added pleasure. I will say to you, I want to reiterate just a few things I saw Alan Resnick just from as an old man. One, mineral oil is a necessity. We've all been doing it. Thank you for bringing that, Nirav. If you're not, you're silly, slide the graph up. We never make a straight incision. Dr. Stedman taught us that. If you do a partial knee and you do a total knee, you're going to have anterior knee pain. So stop worrying about it like a sports medicine geek. Okay, so make an oblique incision and don't get the infrapatellar branches of the saphenous nerve of all of them, and you'll solve that problem. If you are going to do a VTB for whatever reason, then stay in the damn room and don't let a fellow close and don't over tighten the patella tendon, and you'll find they will do well. And I'll be curmudgeon. Dale Daniels taught us that if you do too many LETs, gentlemen, you will gain arthritis, that everybody gets arthritis in 20 years from doing ACL surgery. That's why you set up for the next procedure, and you may not have to do an internal brace, but just watch the slope. Don't let it be greater than 7 degrees. And if you want to lower your infection rate, don't let the nurse prep and drape. Stay in the darn room and be the doctor that you're supposed to be, because someday it's going to be your knee. And remember, volume kills. So take your time, do it right so you don't get the infections. And you'll find that that's why the three of you and everyone else on here is successful. But remember, it's about the patient, okay? And so I will say to you, we want to avoid the complications that Brian was talking about, and that all of us. There's no reason. It's a gold standard operation. If you're a soft tissue person, it's clear you've brought to mind a great way to improve your technique and stop that displacement. And if you're going to use bone patella bone for whatever reason, as I am, and I'm partial, then do it the right way the first time. And I really thank you it's a great discussion to bring out how to reduce displacement, especially if there are any Europeans, because they believe only in hamstrings still to this day. So thank you for bringing it to light.
Thanks, Kevin. I mean, I think it's very important, Kevin, right? We historically follow kind of our choices in grafts partially by the implants of ease of use, right? So the reality is a fixed button loop on the femoral side is probably the best for no displacement. But even as Brian said, we went away from that of doing the math and measuring and so forth because of ease of use. But part of it is because of our ease of use constructs have grown in the US, we've also introduced all these variabilities of displacement, elongation, and all those other factors. And that's why we're trying to get back to the level of trying to solve one of those points, at least 50% of it at time zero.
You're right. You're right. So it's great.
Yeah, that's a beautiful way, beautiful summary, Nirav, because I often think about this and I think, what is the next generation of surgeons? I count a generation of surgeons as about 10 years, a generation in life as maybe 20 years. But what are they going to think? And I think we may get to a point where we're able to optimize biology, optimize mechanics, and then we won't be harvesting autografts because we're going to have allografts that we can seed or biologically improve to the point where we eliminate the donor site morbidity. And I always, somebody out, the residents of fellows, they'll say, well, when's that happening? And I'm like, I'm pretty sure that my mentors thought that it was going to come in my generation. And so I don't know when that's coming, but I think eventually we will look back and be like, gosh, can you believe those guys were harvesting autographs to do this procedure? But right now the data still shows that's the best thing we have. And if we can improve elsewhere, then maybe we get a few millimeters of wiggle room that we can use somewhere else.
Yeah, no, great. Ira, I'll pass it back to you to be respectful of everyone's time because we're past at 6:02. But I think this was very insightful. I hope this gave a little bit of constructive kind of discussion on ACL fixation and honestly enlightened everyone a little bit on the displacement discussion that has kind of gone away as we've evolved in fixation methods.
Thank you. This was a great session. I want to say welcome to the fastest hour in orthopedics. All right. We got many ACLs done tonight in just 1 hour. Kevin doesn't like that. I know the speed part, but we'll
Don't ever say it, Ira. They'll lower your reimbursement. Take your time.
I
That
love it,
is right.
Kevin. Don't ever bring speed to the equation, or it leads to CMS reimbursement delay. I always say every case takes me 5 hours.
You got it, buddy.
Yeah, don't ever publish how many cases you can do with no complications.
Right.
Thank you.
So with that said, I want to say thank you to everyone. This was an amazing session. It will be available on our YouTube channel, on our open mic minutes, and parts of it will be available on LinkedIn, ViewMedi, Spotify, and Apple. So I want to thank everybody for a good night and appreciate your time.